Thank you, David. I'm usually the voice of God, but I see you've got a new voice of God here. I am honored to be here. It is a phenomenal meeting to have this many surgeons. I graduated from medical school in 1969 and had my introduction to spectacular cardiovascular surgery at Stanford, where I did my internship, and then ended up doing medicine and cardiology out there. So I've been around fabulous cardiac surgeons all my life. And so I'm deeply honored to be here. When Blaise Carabello and I were junior faculty at the University of Virginia in the 70s, young Irv Krohn was a surgical resident. And so I am deeply honored to be here. You know, Dr. Chitwood has given you a fabulous history. I'm going to take us down a few notches. I love this quote: drag a $100 bill through a trailer park and no telling what you'll come up with. At this meeting, maybe a few cardiologists will come here. I've actually seen Dr. Chitwood at his birth here. This is actually meant to honor our Japanese colleagues who we still think about and keep in our thoughts. Dr. Chitwood, as you know, is a tremendous photographer, and this is him at his birth coming out and doing his trick to take his photograph. I am pleased to be here with so many smart cardiac surgeons. Many of you are probably in the Mensa Society. You know, the Mensa Society is for people who have extremely high IQs, so the Washington Post invited the readers to take this challenge, adding or subtracting or changing one letter, thereby giving a new definition. One of my all-time favorites is ignoramus, a person who's both stupid and an asshole. I like reincarnation. Dr. Chitwood, this doesn't have anything to do with you coming back to life as a hillbilly. Boson, the substance surrounding stupid people that stops bright ideas from penetrating. The boson layer, unfortunately, shows little sign of breaking down in the near future. And for me, the Doppler effect, the tendency of stupid ideas to seem smarter when they come at you rapidly, and that's what I'm going to be doing. Dr. Chitwood's given you this fabulous history. This is actually a medical instrument. This is called the Thermidor. It was a tobacco smoke enema, where the idea was that you put the end of this bellows into the rectum of a drowning victim and blew smoke in there, and it would resuscitate him. Obviously it didn't work, but it did give credence to the term blowing smoke up one's ass, and that's what I promise I will not do to you. Okay. So this is Dr. Bono is going to talk and Blaise about the guidelines. This is unfortunately what our healthcare guidelines look like. So we'll try to keep this simple. When we're dealing with somebody with mitral regurgitation, obviously we examine the patient. We want to know what their symptoms are, and then we quickly want to know the etiology. We do want to know the severity. Importantly, we want to know what the impact is on the ventricle, the left ventricle, the atrium, and the right ventricle, as well as pulmonary pressures. And then ideally with an imaging technique, if you can get all that, you'd like it to be able to aid you as master surgeons in doing the right therapy. So really, I think when we look at imaging, can it aid you with etiology? Can it aid you with severity? Can it aid you in making the right decision to do the right procedure at the right time? We do have CT, and Dr. Chitwood has shown a fabulous image. There is some phenomenal things going on with CT, with image processing, where you can take images now and manipulate them, be able to rotate in. This is from a offline analysis of a complex CT. This is actually a rheumatic mitral valve, where you can begin to take the CT images, rotate them, look at the subvalvular apparatus, be able to see, not too dissimilar from what Randy showed with the MRI, to show those. The problem with CT is it's not ubiquitous, and it does, even though the fast imaging machines have less radiation, it still is a radiation technique. Cardiac MRI is this is not advancing for me, if you could advance it. Cardiac MRI is, well, it's not going to, huh? I am trying the wheel. Can you advance those slides or not? Okay. That's interesting. Okay. Any success in the back? Or do you guys have control in the back, or does anybody up in the... There you go. Okay, cardiac MRI gives us fabulous anatomic and physiologic information, and they can with super processing, begin to look at the structures of the mitral valve. Obviously, it has the ability to quantitate regurgitant fraction and to quantitate volumes and ejection fraction, and many would say would be the gold standard. It is of great value also with ischemic and secondary mitral regurgitation, and many would say it is the way to look at viability. Its spatial resolution and temporal resolution is similar to echo. It does have, as echo has tremendous disadvantages in that it's operator dependent and has not been quantitated the way it should. MR has challenges that we see there listed on the right. It is a magnetic technique, and I think the major difference between echo, which I'll spend the remainder of 10 minutes talking to you about, and MRI is that echo is portable. It can go with you to the OR. It can go with you to the ICU. That's a portable MRI unit being loaded onto the top of the hospital, so there are some disadvantages. I have been at the forefront of echo all my life. I do believe that when done well, and that's the important thing, that it is a tremendous technique that gives you global anatomy, can give you function, can give you hemodynamics, and can aid you in directing therapy, and I think is the primary technique that we should use to look at primary valvular versus secondary, and again to go through this list of what is the severity, what is the impact, and how does it aid you in timing. While most of you as surgeons have certainly appreciated transesophageal echo, and it's played an important role in the OR, and three-dimensional TEE, which I'm showing below, this classic P2 prolapse, TEE, I think, has a very defined role in helping to better understand the anatomy, and I'll show that to you in a minute. And I do want to show you that there's some unique ways that I think it can plan the operation that you would do and can aid you in assessing the outcome of that. But don't forget transthoracic echo. Try to make this very simple for you. You can see here that's where the co-captain sits in the nose cone if you wondered about an airplane. What we want transthoracic echo to do is to do everything highlighted in yellow, to quantitate, to look at LV, to look at LA, to look at pulmonary hypertension, and then to use it with exercise. A transthoracic echo is very similar to a TE. It's just in a different format for you, and from this article we've illustrated this. A peristernal long-axis view can certainly allow you to look at the differentials. On the upper right is a flail posterior leaflet. Bottom left is an ischemic cardiomyopathy, and bottom right is a rheumatic mitral valve. And it's obviously here easy to see, although you should be able to do this by your physical exam, the difference between a primary valve and a secondary valvular problem. Short axis views are a little bit backwards from your surgical view, where medial is now shown to the left of the screen, but you can begin to ascertain all of the aspects of the valve just as we do with TE. This patient who looks like they've got severe posteriorly directed jet of MR actually has that because of a cleft mitral valve. This patient was sent in to rule out anterior leaflet mitral valve prolapse. So the short axis views allow us to begin to look at the mitral valve in the anatomic way that we look at it with TEE. Here's a patient who has a flail anterior leaflet, posterior leaflet, because I'm thinking of the previous patient, anteriorly directed jet. And you see when we look with the short axis views, then you can see that it's actually P3, the medial aspect of the valve, with severe MR. So that the mitral apparatus can be ascertained both with transthoracic, long axis, short axis, and the apical views. The upper right is an ischemic cardiomyopathy. The lower left is a flail posterior leaflet with moderately severe TR and markedly elevated right-sided pressures. So we use this technique to aid in not only quantitating the severity and etiology, but timing, because we don't want to wait for a patient to be like this patient, who has this one I've shown, who comes in with a flail posterior leaflet, severe MR that you can easily see. The end-systolic dimension is far above the guidelines. It's 4.7. The EF is down. These movies are just not playing. I apologize on this system. And this patient has right-sided pressures that are in the 60s or 70s. So this patient has missed all of the guideline criteria, and this is the challenge for the cardiologist. But the echo can give you that criterion. And so we use the transthoracic echo to quantitate MR by various techniques. We do critically measure right-sided pressures. We want to look at the left ventricular size, as you know from this article, that clearly has shown that 4 centimeters for an end systolic dimension is really the cutoff. But in fact, if you look at the hazards ratio, the cutoff really was a little bit earlier. So we would like to think that we should be looking at these ventricles at 3.7, 3.8. We also look at the LA size on a apical view. And Maurice Serrano and his colleagues have shown that LA size is also not only a predictor of AFib, but is also a predictor of increased cardiac adverse outcomes. So all of these are the things we're looking at. And finally, in the asymptomatic patient, we use stress echo. This is a gentleman I sent to David, a 79-year-old, very active. I don't know why none of these movies are playing, but he's got P2 flail. And at rest, his right-sided pressures were in the 40. We exercised him. You can't see this, so this makes it quicker. And post-exercise, his RV pressures went up to 75, even though he did 9 minutes on the treadmill. His left ventricle and right ventricle do not like this MR, and it's a way to decide to quickly move those patients to surgery. So let me go through these and show you finish up with this. And that's really the beauty of three-dimensional transesophageal echo. It is your anatomy. It is the anatomy that you're used to seeing. Bottom left, a normal mitral valve. Middle, a Barlow's, and right is a P2 prolapse. It can also aid you in detecting clefts. And then this is the gentleman who I showed previously, who's got a flail P2. You can easily see this with the TEE and the 3D TEE. And in the bottom 2 frames is the QLab, or the automated analysis of this mitral valve. Now, this is a tedious thing to do and is not routinely done, but begins to give you that roadmap that aids you preoperatively in thinking about the valve. Remembering that the mitral valve, though, as David has emphasized, comes in many shapes and sizes, a P1, a P2, a P3, P1, P2, P3 prolapse. And in these images from Tyrone David's group, this is a P1, P2 prolapse. And as you can see, there's also a cleft between P1 and P2, or in this patient who has a very complex valve with P2, P3, A3. And then when we look at this, you can begin to get a feel for this valve, and it also involves the posterior medial commissure. So excellent anatomic information, and in Barlow's you obviously can see the complexity of the valve. I want to finish with this, and this is something that I think is very exciting. We will not get into secondary mitral regurgitation, but that's that now there are methods to quickly online analyze these valves. Dr. Manny Vannon and the colleagues at Ohio State have been able to do this, and if you think about diagrams out of Alon and David's book, an excellent book, of all the measurements that you all need to do an excellent repair, while I've shown you these QLab analysis, again, these take some time to do. This takes about 10 minutes to reconstruct if you do it right, where you have systems now that can run these images and generate online within a matter of seconds an analysis of the valve by just running the three-dimensional images through a supercomputer, and you begin to get a view of the valve. And this is too bad none of these are playing. They play. This is that patient with the P2 prolapse, and this is what the QLab would look like. But again, going back to the measurements that you want, we can run this through, and it'd be nice if it played, we can run these through taking the images, you run them through a computer, and then you begin to get a instantaneous diagram of the mitral valve where you can begin to measure the intertrigonal distance, the intercommissural distance, the anterior leaflet and posterior leaflet height. And it's very similar to what you would be doing in the operating room. And we're doing this very, very rapidly so that I think it aids you, as you would do in the OR, with sizing techniques of knowing preoperatively what you're going in to see, knowing the heights, knowing the measurements that you have, to be able to look at proper sizing and proper operative techniques, be able to measure the posterior leaflet online, and do all the things that you would do, so that the three-dimensional echo, TEE now, with a quick analysis by just an analysis program, can spit all this out for you and aid you in planning. And so I think it can also help you in assessing outcome. If you can go to the very last slide. So I've taken you through a quick sort of tour of the mitral valve. I do think that we have tremendous imaging techniques. They never, ever supplant excellence in clinical decision and clinical decision making. But I think, if you'd go to the tail end slide, if you would, please. I think that echo clearly has a role. It has challenges. But for all of us, I clearly believe that being able to take imaging techniques and aid you in making the right decision to do the right procedure aids all of us in helping the physicians. Thank you very much.